Chronic obstructive pulmonary disease, or COPD, is the obstruction of airflow due to inflammation of the airways due to chronic bronchitis and destruction of the alveolar wall and dilation of the airspace, which is called emphysema. Most of the patients will have both of them. Now, the destruction will lead to a decrease in the elastic recoil of the lungs. This destruction will result in a decrease in the forced expiratory volume in 1 second and in the forced vital capacity. And it will also cause an increase in the total lung capacity because of the air trapping that happens. COPD is most commonly triggered by inhalation of tobacco smoking and also by occupational pollutants like the dust and silica. The common presentation of COPD is shortness of breath, worsened by exertion, intermittent exacerbations with increased cough, sputum, shortness of breath, and it is often brought by an infection. Bowel chest from increased air trapping, and muscle wasting and cachexia are also common. If the case describes a patient with the same presentation, but the patient is young and a non-smoker, then you should consider alpha-1 antitrypsin deficiency as the most likely cause. We will have a different video talking about this disease. What about the diagnostic test? Now, the best initial test is having the chest X-ray, which will show increased anterior-posterior diameter, air trapping, and flattened diaphragms. The most accurate diagnostic test is pulmonary function test. It will show decreased FEV1, decreased forced vital capacity, decreased ratio under 70%. Also, an increased total lung capacity will be found due to an increase in residual volume. DILCO will also be decreased, and there will be incomplete improvement with albuterol and little or no worsening with methacholine. Now, do you know what happens with albuterol and methacholine when we use it with asthmatic patients? If you don't know, you can go back to our video about asthma to find out. CBC might show increased hematocrit due to chronic hypoxia. EKG will show right atrial hypertrophy and right ventricular hypertrophy, atrial fibrillation, or multifocal atrial tachycardia. The echo also will show right atrial and right ventricular hypertrophy and pulmonary hypertension in advanced disease. When we perform the flow volume loops in a patient with COPD, you will find that the patient will have obstructive lung volumes. The obstructive lung volumes are more than the normal lungs. That's called shifting to the left. All the volumes are increased, while in the restrictive diseases, all the volumes are reduced, and the loops will shift to the right. Another difference between the obstructive and the restrictive is that the forced expiratory volume in 1 second is more dramatically reduced compared to forced vital capacity. That is why the ratio is reduced. While in the restrictive diseases, the forced vital capacity is more reduced or similar to the reduction in the forced expiratory volume in 1 second. That is why the ratio is increased or normal. Let's talk about the treatment of COPD. We will divide the treatment into 3 groups to help you memorize them. First group are the things that improve the mortality and delay the progression of the disease. Number 1, smoking cessation. Number 2, oxygen therapy. But we only use oxygen if the oxygen saturation is 88% or lower. The threshold is lower when the patient has pulmonary hypertension, high hematocrit, or cardiomyopathy. We use the oxygen in these patients if the saturation is 90% or lower. Influenza and pneumococcal vaccinations also improve mortality and delay progression of the disease. Mortality benefit is directly proportional to the number of hours that the oxygen is used. Avoid placing a patient with COPD on a high-flow 100% non-breather mask. Use only as much oxygen as necessary to raise the oxygen saturation above 90%. Next are the things that improve symptoms. we have short-acting beta agonists, we have anticholinergics, we have steroids, we have long-acting beta agonists, and we have pulmonary rehabilitation. As you know, in asthmatics, if the patient is not controlled with short-acting beta agonists, we move on to inhaled steroids. But with COPD, most patients are not improved with the short-acting beta agonists, but we do not move on to the inhaled steroids. We move on to anticholinergic first, like tiotropium, and then we move on to the inhaled steroids. Inhaled anticholinergic agents are most effective in COPD. Third group is the things that possibly improve symptoms. In a person on short-acting beta agonist, long-acting beta agonist, long-acting muscarinic antagonists, and inhaled steroids, and you want to keep them off long-term oral steroids, you can try thiophyllene, roflumilast, which is a phosphodiesterase 4 inhibitor, and lung volume reduction surgery. Unlike in asthma treatment, cromolyn here is not useful. Also, leukotriene modifiers are not useful, but you can use them in asthmatic patients. N-acetylcysteine is also not useful in the treatment of COPD. Let's talk about the treatment of acute exacerbation of chronic bronchitis. Ipratropium can be used, and it's the only anticholinergic agent used in acute exacerbations. The treatment is mainly oxygen, albuterol, a bolus of steroid, which is very similar to the treatment of acute exacerbation of asthma. And we add to this treatment, we add antibiotics. The antibiotics should cover Streptococcus pneumonia, Haemophilus influenza, and Moraxella catarrhalis. The most effective agents are macrolides like azithromycin, cephalosporins like cefuroxime, amoxicillin and clavulanic acid, and quilinols like levofloxacin. Second-line agents are doxycycline and trimethoprim and sulfamethoxazole. Finally, ineffective modalities for the treatment of COPD. Intravenous aminophylline in acute exacerbation is not useful. Aminophylline and thiophyllene can be used in long-term management, but they are not used in acute exacerbations. Thiophyllene helps in the relaxation of smooth muscles, and it reduces airway responsiveness to histamine, methacholine, adenosine, and allergens. Long-term or maintenance antibiotic treatment in COPD is incorrect or wrong. Doing spirometry in asymptomatic patients as a screening method is also wrong. N-acetylcysteine does not improve respiratory function, and it is irritant and can cause bronchospasm. After watching the video, which of these questions can you answer? If you still have some difficulty in answering some of them, you can go back and watch the video. And if you want to know more about the asthma treatment, you can go to our video about asthma management. If you like the video, please hit the like button and subscribe to our channel to see more of this content. And while you're at it, share it with your friends.